Welcome to today's deep dive. We're diving into a topic that I'm sure we've all thought about, especially if you have kids, wheezing and asthma in children.
Yeah.
And to guide our deep dive today, we have excerpts from a medical textbook.
Yeah.
So get ready to kind of decode those coughs and wheezes.
It's so true. I mean, these are some of the most common concerns that we hear from parents.
Oh, I bet.
You're a new parent, you hear that wheezing sound from your little one.
Oh my gosh.
It's very alarming.
I can only imagine.
So let's dive into, the science behind this.
Yeah, let's do it.
And see if we can separate sort of the worrisome wheezes from those that are totally developmentally normal.
Okay.
And so our source material starts by talking about wheezing in infants. And it turns out it's not always what we think.
Really?
So infants are actually more prone to wheezing just because of their anatomy.
Okay.
Those tiny airways are still developing, and their chest walls, the cartilage in their trachea, is softer than in adults.
Makes sense. Their airways are still under construction.
Exactly. So if you think about like a soft rubber hose versus a hard plastic one,
Yeah.
that soft rubber hose is more likely to kind of collapse inward,
Right.
especially when you're trying to blow air out, which is essentially what happens when we exhale.
Okay.
And so for infants, that wheezing sound often just means that their airways are still developing. It doesn't necessarily mean that there's a chronic condition.
That's good news for parents.
Good news for parents, exactly.
But if it's not always serious, what is causing the wheezing in babies?
Well, most of the time, it's something called bronchiolitis,
Okay.
which is a very, very common respiratory infection we see in infants.
Bronchiolitis.
hmm
So when a baby has bronchiolitis, what's actually going on in their airways?
So essentially, the small airways in their lungs, the bronchioles, become inflamed.
Okay.
And that inflammation leads to swelling, and then you get mucus and cellular debris that builds up. And that buildup makes it harder for air to flow freely.
And that's what leads to that wheezing and the coughing and the difficulty breathing.
Exactly. And sometimes it can even cause feeding difficulties
Oh, really?
because it's hard to breathe and eat at the same time.
Oh, my gosh, yeah.
And actually, Figure 418.1 in our source material shows a really great visual of this.
Oh, wow.
You can actually see how narrowed the airways become.
Poor babies.
Mhm.
So, but there's good news, right? It usually runs its course.
That's right. So it's usually caused by a virus, and in most cases, it doesn't lead to long-term complications.
Okay, so it resolves on its own.
Mm,
But parents still need to be vigilant, right? Watch out for those more serious signs.
absolutely. Recognizing the signs of serious illness and seeking medical attention when necessary is always, always important.
Always better to be safe than sorry. Now, our source material also mentions acute bronchitis. Is that the same as bronchiolitis?
Not exactly.
Oh.
So while both are very common respiratory illnesses and often come after a viral infection,
Okay.
the main difference is that bronchitis really affects those larger airways. Oh, okay.
Not the tiny bronchioles that we see in bronchiolitis.
So it's a different part of the respiratory system.
Exactly. And with bronchitis, the main symptom you're going to see is a persistent cough that can last for, 1 to 3 weeks.
So in both cases, parents are dealing with coughs. They're dealing with potential wheezing. It seems like it would be really hard to tell the difference.
It can be. There are subtle clues that doctors can use to tell them apart, but really relying on a professional diagnosis is the best course of action.
Which makes sense, especially since you said it often follows a viral infection. You would want to make sure you're treating the right thing.
Exactly. You want to treat the root cause and not just mask the symptoms.
Right. Okay. So shifting gears a bit, let's talk about asthma.
Okay.
Now, this is a chronic condition.
Right.
So we're talking about inflammation and narrowing of the airways, but unlike bronchiolitis or bronchitis, it's not acute.
Yeah, and asthma is so interesting because you have this interplay between genetics and environmental factors.
So it's not as simple as saying, asthma runs in my family, so my child will definitely have it.
So there's more to it than just genes.
There's more to it. It's really a combination of predisposition and triggers. It's more like a puzzle where both your genes and your environment are contributing pieces.
Okay.
And figure 169.1 in the text actually does a really good job of showing that.
So there's no single asthma gene. It's multifactorial, it sounds like.
Exactly.
It almost makes it seem like it'd be really difficult to predict whether a child will develop asthma or not.
It is, and that's actually a huge area of research.
Okay.
figuring out which wheezing infants will actually go on to develop asthma is a big challenge.
So just because my baby is wheezing doesn't mean they'll have asthma.
Exactly, not necessarily. And our text highlights that if wheezing starts after 18 to 36 months of age, that's actually a stronger predictor than wheezing in infancy.
Oh, interesting. So the timing of the wheezing matters.
The timing matters.
Okay. Are there any other warning signs?
Yeah, family history is huge.
Okay, that makes sense.
If one or both parents have asthma or allergies, that definitely increases the chances.
Okay, so family history. What else?
Maternal smoking during pregnancy has also been linked to increased risk of wheezing and asthma in kids.
Right, because of the effects of smoking on the lungs. Makes sense.
Exactly. And then there are a few other factors that are mentioned in Table 4NE3.1 and 169.1 of the text.
Like what?
Things like eczema,
Eczema. Really?
which is a skin condition,
Gross.
persistent rhinitis,
Mm-hmm.
and even if a child's immune system is sort of already primed to react to certain allergens,
Interesting. So you wouldn't think with eczema.
it seems counterintuitive.
Yeah.
But eczema, allergies, asthma, they all kind of go together. They're all part of that. Remember that puzzle we were talking about?
Right.
It's all part of that big immune system puzzle.
So family history, maternal smoking, eczema, persistent rhinitis, and then just that allergen sensitization. That's a lot.
It's a lot to keep track of.
It is.
But the good news is that most infants who wheeze won't develop asthma.
Okay.
However, early identification and management are essential for those who do.
That is reassuring, but it just highlights how complex this really is,
Yeah.
which actually makes me even more curious about the diagnosis and treatment side of it.
Yeah, there's a lot to unpack there.
You know, when we talk about asthma, I think wheezing is like the first thing that comes to mind.
Right.
But it sounds like there's more to the story, especially with kids.
Yeah, you're right. Wheezing is definitely a hallmark symptom, but asthma can actually show up in other ways, and especially in younger children who maybe aren't able to communicate exactly what they're feeling.
So what else should parents be looking for besides the wheezing?
So, asthma can be sneaky.
Okay.
In addition to wheezing, kids might have a cough that just won't quit, especially at night.
Okay.
They might complain about their chest feeling tight or even have a hard time catching their breath.
So it's not always like that, really dramatic gasping for air situation.
Not necessarily. Sometimes it's much more subtle, especially in those younger kiddos.
Right.
A cough that just lingers, especially a nighttime cough, might be the only real clue
Wow.
because they might not even be able to tell you that their chest feels tight.
And I imagine the way those symptoms show up is different depending on how old the child is,
Absolutely.
by what you see in a toddler versus a teenager.
You got it. And understanding those little nuances is key for parents.
Absolutely. Speaking of understanding, our source material mentions figure 169.2, and it's a diagram of what's happening inside the airways during an asthma flare-up.
Right, shows the inflammation.
It's pretty amazing to see how the body reacts.
Yeah, figure 169.2 really highlights how complex this condition is. It's not just constricted airways, it's this whole immune response that's happening.
Wow.
You can practically see the inflammation in that diagram.
And that's what's causing those tight chests. That's what making it difficult to breathe. And, that makes me think about something else. Our source material mentioned asthma mimickers. So it's not always asthma.
You got it. As we've been talking about, asthma symptoms can be all over the place.
Right.
And those symptoms can look like other conditions. So
Yeah.
it's not always a slam dunk diagnosis.
So what are some of these conditions that can kind of masquerade as asthma? What should parents be aware of?
One that we see pretty frequently is GERD, gastroesophageal reflux disease.
GERD. Really, I always think of that as heartburn. I wouldn't put those two together.
It's more common than you'd think, especially in kids.
Okay.
GERD can actually cause coughing and wheezing, especially at night, because that stomach acid can irritate the airways.
Wow. So a kid could be treated for asthma when it's actually GERD.
That's why it's so important to have a thorough medical history and a good physical exam. Doctors have to consider everything and rule out those other possibilities.
So it's not just about treating symptoms. It's really about getting to the root of it.
Exactly.
Okay, so GERD is one mimicker. What else?
Sinusitis is another one.
Oh.
Inflammation of the sinuses.
That makes sense because it's all connected, right?
It's all connected, exactly. And then there are things like structural abnormalities, which aren't as common,
Okay.
but still important to think about.
Structural abnormalities. That sounds a little scary.
I understand. But these are usually diagnosed pretty early on.
Okay.
Our source material, Table 169.5, gives some examples.
Okay.
One is called laryngotracheomalacia, where the cartilage in the airway is just really floppy,
Okay,
and that can cause the airway to collapse.
so it makes breathing difficult.
Exactly. The bottom line is there are a bunch of things that can look like asthma.
Right.
So doctors really have to do a thorough evaluation.
Not just jump to conclusions.
Exactly.
So, speaking of treatment, is that also really complex when it comes to asthma?
It can be, and managing asthma is usually a long-term thing. It's not as easy as just taking some medicine.
So it's more holistic.
Right. It takes a partnership between the doctor, the child, and the family. It's about knowing what those individual triggers are, making lifestyle changes, and working with the doctor to come up with a good plan.
Okay, so where do we even start with treatment? The source material mentions something called a step-up, step-down approach. What does that mean?
It's a way of thinking about how treatment is adjusted based on what each kid needs. So it starts with the least intensive treatment, and then as you go up the steps,
Right.
the intensity increases.
So if it's not working, you go up a step.
Right. And then if it is working, then you can step down.
Okay, so you're not necessarily on a certain medication forever.
Exactly. The goal is to find what works best with the least amount of medication possible.
Okay, so walk me through it. What kinds of treatments are we talking about at these different steps?
Well, it varies, of course.
Sure.
But that first step might be a short-acting bronchodilator,
Okay.
which just quickly opens up the airways.
So that's more as needed, like if they're having an attack?
Right. Quick relief.
Okay. What about long-term control?
Inhaled corticosteroids are usually the next step.
Okay.
Those work by calming down that inflammation in the airways.
So they're more preventative.
Exactly. You take them every day to keep things calm.
Okay.
And if those aren't doing the trick, then the doctor might step up the treatment,
Yeah.
maybe by increasing the dose or adding something else, like a long-acting bronchodilator.
So there are other medications besides those two?
Oh, yeah. The source material goes into a few others.
Okay.
Things like leukotriene modifiers, which block certain chemicals that trigger asthma symptoms.
Okay.
And even something called biologic therapies.
Biologic therapies, those sound intense.
Yeah, those are usually for more severe cases.
Okay.
But it's a fascinating area of research.
That's
The
true.
point is, there's a menu of options.
Right.
And a doctor can help families find what's right for them.
So it's all about finding that balance.
Yes. And medication is just part of it.
Right, because we can't forget about those lifestyle changes.
Exactly. There are a lot of non-pharmacotherapeutic things that families can do.
So what are some things that families can do at home?
The big one is minimizing those triggers we talked about.
Okay, like the dust mites, pet dander, pollen.
All of that. And a lot of times that means changing things up at home,
Like what kinds of changes?
using dust mite covers on the bedding,
Okay.
washing bedding in hot water, sometimes even getting rid of carpets.
Oh, wow.
So it's about making the home environment as asthma-friendly as possible.
Asthma friendly. I like that. Are there other things besides the home environment?
Definitely. Our text actually mentioned that breastfeeding for more than 4 months might help reduce the risk of asthma.
Oh, interesting. I did not know that.
It's amazing, right? It really highlights how important it is to look at the big picture.
Totally. Anything else about lifestyle?
Our source material also talked about regular exercise and a healthy diet.
So you're not saying that kids with asthma can't be active?
No, not at all.
Okay.
Regular exercise can actually make their lungs stronger.
Oh, wow. And that makes asthma easier to manage.
So again, it's all about finding that balance.
Exactly. It's about empowering kids to live their lives.
Right. And to feel empowered, they need information, right?
Yes. Knowledge is power.
Okay.
The more you know about asthma, the better you can manage it.
The source material also mentioned something called a written asthma action plan.
Yes.
What is that?
It's basically a roadmap for what to do when a child starts having symptoms.
Oh, okay.
So you know what to do. You don't have to panic.
It takes the guesswork out of it.
Exactly. It tells you which medications to give, when to call the doctor, even when to go to the ER.
That's huge.
It really helps families feel prepared.
Yes. So we've covered a lot.
We have.
We've talked about the different ways asthma shows up,
Right.
the importance of getting the right diagnosis, that step-up, step-down treatment approach,
Yep.
those lifestyle changes.
Right.
But we haven't really gotten into those biologic therapies you mentioned.
Oh, yeah.
I'm really curious about those. Me too. It's the new frontier of asthma treatment.
So those biologic therapies, they almost sound futuristic. What are they?
Yeah, they're really cutting edge. Basically, they target very specific parts of the immune system,
Okay.
the parts that are causing those asthma symptoms. Like, they go after the inflammation, but in a super precise way.
So instead of just general inflammation, they're like zeroing in on what's causing the asthma in the first place.
Exactly. And because they're so targeted, they often have fewer side effects.
That's incredible.
Yeah.
So who gets those therapies?
Right now, they're mostly for people who have severe asthma,
Okay.
like folks who haven't had success with the other stuff. Inhaled corticosteroids, those other medications.
It's like another option when the other options haven't worked.
Yeah. And it's exciting. Early research is looking good.
Mm-hmm.
But, it's still new, so we're learning as we go. Like, what about long-term effects?
Right.
Things like that.
Do you think they'll become, more common in the future? These biologic therapies.
Hard to say for sure, but, they have huge potential.
Yeah.
As we learn more about the immune system, we can make even more targeted treatments, really address the root causes.
Imagine that. No more one-size-fits-all. You get a treatment plan made just for you, based on your genes, your environment, all of it.
Right. It's like personalized medicine.
Exactly.
Wow. And hey, maybe one day we can even prevent asthma altogether.
That would be incredible.
Yeah.
So as we wrap up, what are the key takeaways for our listeners? What should they remember about all this?
I think the biggest thing is knowledge is power. The more you know, the more you can advocate for your kid. Make the best decisions for their health.
And that means talking to your doctor.
Yes. Ask questions, share your concerns. You're on the same team.
Right. We've covered a lot. Asthma's complex.
For sure.
Genes, environment, all those other factors. But there's hope.
Absolutely.
Treatment's always evolving.
Yeah.
And with the right management, kids with asthma, they can live full lives.
Totally. They can do anything they set their minds to.
On that note, we'll wrap up this deep dive. It's been fascinating, and we hope our listeners feel ready to learn more. Advocate for the kids in their lives.
Thanks for having me. It's been great talking about this with you.
And to everyone listening, keep exploring, keep asking questions, and keep diving deep.